The following podcast is part of a certified educational activity titled Targeted Therapy for Hereditary Transthyretin Amyloidosis Polyneuropathy, ATTRv-PN. You don't want to miss it. Access the entire activity and complete the post-test at peerview.com/AJT860. Downloadable slides and practice aids are also available.
Good afternoon, everybody. Thank you for joining us for this talk, and thank you for everybody who's joining us virtually. They're pretty active with the questions, so we like that. We're going to be talking about hATTR amyloid neuropathy, and we're going to be speaking about how to diagnose this disorder, how to think about it, how to work people up, and then how to, importantly, treat them, because this has been really a revolution in our practice. So please welcome Dr. Michelle Kaku, who is a professor at Mount Sinai, and she's been doing amyloid for quite some time now, started at Boston University, one of the major centers of amyloid in the world, really. And I'm Shafiq Karam at the University of Pennsylvania.
So our goals for today, as I mentioned, is to increase your index of suspicion for ATTRv polyneuropathy using patterns of signs and symptoms across organ systems, equipped with strategies for diagnosing and treating patients, and then we're going to provide you with guidance on developing system of care for ATTRv polyneuropathy. So this is the protein in question and we think about this a lot. This is the transthyretin, short for TTR. And the trans is for transport, thi for the thyroxine, and the retin for retinol, vitamin A. So that's what it does. It transports vitamin A and retinol and the thyroxine. And it's made mainly by the liver. It's also made in the eye, in the brain, and some other organs locally. But the main producer is the liver, which has implication on the treatment, as we will see later. It's a tetramer, so you have 4 parts of the protein, as you can see, and it tends to dissociate and then reassociate normally. But the problem happens if it misfolds. And one thing I would like to point out is that amyloid is just a generic term for multiple disease that happens in humans. So we have over 30 types of amyloidosis in humans. And what we're talking about here is transthyretin. It's very important to separate it from the other most common, which is AL amyloidosis, because they're completely different. You have a protein disorder, mainly genetic, and could happen also in the elderly. And the other one, AL, is a type of malignancy, if you will, that is more treated with chemotherapy and stem cell transplant. However, they do share things together, and this is why it's important to work people up correctly, because sometimes they can overlap as well. So dysautonomia is a major symptoms of amyloid neuropathy, and whenever we have dysautonomia in a patient and neuropathy, the first thing, the second thing, and the third thing we think about is amyloidosis. So really important to keep that in mind if you have a patient with orthostatic hypotension, GI issues, diarrhea, feeling full early, and as a result losing weight and so forth. However, there's some things that are more specific for ATTRv. So biceps tendon rupture, you see that really in wild type. You don't see it in AL amyloidosis. And one of the major reasons is AL is a rapidly progressive disorder. The ATTRv or the wild type are kind of more slowly. So you have much more hypertrophy on the echo for the heart than AL, and then you have tendon issue and carpal tunnel syndrome more frequently and so forth. Another thing that is interesting about ATTRv, and we're at the ANA here, so it does affect the brain and the eye as well. So something to keep in mind, and we're going to see in one of the cases that we'll present later how this manifests. And it's also a clue that you can be dealing with ATTRv amyloidosis. It's also important to separate from other inherited amyloidosis, because we do see some patients refer to us sometimes for treatment for ATTRv with the current treatment that we have right now, but unfortunately they don't apply. For example, if you have a patient with Gel-Zolin amyloidosis, which is a genetic condition, you cannot treat it with the same treatment that target TTR. So what is the first step that happens in this disease? The first step is misfolding of these monomer. And when that happens, kind of starts a sequence of events which will eventually get to the beta-pleated sheeted and the amyloid fibrils, which will stick to organ, infiltrate the heart, the nerve, the muscle, the GI tract, and the tenosynovium, for example, in carpal tunnel syndrome. And it's going to cause problem. And this problem can be severe enough to lead to death. For example, if the heart is involved without treatment, the average survival is 3 to 4 years. People have many issues with this condition. It's a rare condition, so a lot of time people don't think about it. A lot of physicians have never encountered AL or ATTR amyloidosis, so there's a significant delay of diagnosis. And the problem is when you delay the diagnosis, you're going to have irreversible organ damage. The other thing, it is a genetic disorder, and it impacts people significantly from both a psychological and social problem. So if you, for example, a patient who saw their father, suffer, get to the bathroom every day 8 to 10 times because of diarrhea, couldn't stand up because of orthostatic hypotension, and then die basically of cachexia and malnutrition. Imagine how, and without the diagnosis obviously, imagine how impactful, these are all real story by the way, can be on the patient. And then it's autosomal dominant, so if they get the diagnosis, if they are tested for genetic and they found that they do carry the variant, then they're gonna live in fear. When is this disease gonna start? And then if they don't have the genetic, they're gonna live in guilt because well, my brother has it and I don't, and they're gonna feel guilty. So really when you sit down and talk to these patients, they are really suffering, and there's a big toll on, and then, the other question is when do you start treatment? Because the penetrance is not 100% and the age of onset varies. So it is kind of a challenging situation to be in. So I'm going to transition now. Dr. Kaku will talk about the neurophysiology of ATTR polyneuropathy and the best practice for early diagnosis.
So taking a step back and thinking about amyloid worldwide, there's more than 50,000 individuals that have hereditary transthyretin amyloidosis. This is actually probably an underrepresentation for what actually exists. The most common mutation worldwide is the V30-MET or VAL30-MET mutation. This is predominantly a Portuguese mutation. There's pockets in many other areas around the world, including in Brazil, Japan, and many areas in and around Europe. In the United States, the most common mutation is the V122I or V142I mutation. This is thought to occur in up to 3 to 4% of African Americans. And the mutation is associated with late onset cardiomyopathy, but neuropathy does occur in about 10 to 50% of patients, and I'll talk a little bit about that. The median age of onset is 68. In the United States, the second most common mutation is likely the T60A mutation, and this occurs primarily in Ireland, but there are various pockets around the world, including this previously was known as the Appalachia mutation because there's a very high density, as you can see, in the Appalachia in the United States. There's two systems of nomenclature which are used to refer to variants. There's the DNA level and then the protein level. The numeric location used in the protein level nomenclature is 20 units higher than in the DNA level. So for example, V122I is the DNA level nomenclature, and the corresponding protein level is actually V142I. And this can be a little bit confusing, but essentially they refer to the same variant. Different mutations present with different phenotypes. Historically, we've put all of the mutations into this primarily neurologic or primarily cardiac manifestation, but really many of these mutations have both. The V30M mutation, again, the most common worldwide, has an earlier onset form, which tends to affect the neurological system very early. It also has a later onset, which has more of a mixed phenotype. And then, as I said before, the V122I phenotype, most common in the United States, is primarily cardiac. The neuropathy and amyloidosis is going to present in your typical axonal length-dependent stocking glove distribution, but Small fibers may be affected early and exclusively, and so it's one of the diagnoses that you should think of in a pure small fiber neuropathy. Think about amyloid, especially with the V30M mutation, but also in different mutations. And this will, of course, affect pain and temperature distally in the toes and progress upwards over time. Later, you have your larger myelinated sensory and motor fibers affected, and that's going to impair your light touch, vibration, joint position sense, and eventually motor weakness. These patients left untreated, especially in aggressive neurologic forms, can end up in wheelchairs with extreme disability requiring assistive devices to walk. Just a moment here to think about the diagnosis and workup of these two types of neuropathies. Your large fiber neuropathy is going to have abnormalities on an EMG with axonal denervation, and then your small fiber neuropathy is going to be likely normal on EMG. So this may only be diagnosed with, for example, a skin biopsy looking at your intraepidermal nerve fiber density. In your patient presenting with neuropathy, there are a few red flag signs that should make you think about amyloid. So one is the very rapid rate of polyneuropathy. So this is not your sort of slow diabetic neuropathy progressing over many, many years. Oftentimes this presents very rapidly, and early motor weakness as well. So if someone is presenting within the last year or two and already has weakness from the neuropathy, should maybe raise a red flag. Another is early autonomic dysfunction. So I do a full screen in my neuropathy patients asking about lightheadedness with standing, dry eye, dry mouth, erectile dysfunction, diarrhea, constipation, or oftentimes alternating diarrhea, constipation, bilateral carpal tunnel syndrome, and prior surgery for carpal tunnel syndrome. Very often patients have this history. And then accompanying prior history or symptoms from other organ systems. So for example, cardiac manifestations can be shortness of breath, arrhythmias, CHF, notably with preserved ejection fraction, features of hypertrophic cardiomyopathy, often like very low voltage EKG. Musculoskeletal manifestations can be rotator cuff tears, bicep tendon ruptures. I've also seen extensor tendon ruptures in the arms. Ophthalmologic manifestations may include vitreous opacity, so patients may report a lot of floaters, periorbital hemorrhages. Renal-wise, you can have renal failure or proteinuria. And then GI-wise, as I said, constipation, diarrhea, or unintentional weight loss that's relatively rapid. You always want to ask about a family history of amyloid, but many times this is the first time anyone in their family has been diagnosed. So you may instead get a history of, oh yes, my father or my mother died very early of cardiac death and or they were in a wheelchair for an unknown reason. And you may hear that multiple family members have had similar history. This is your opportunity, again, to be the first one to diagnose one person in the family so that the rest of the family may be diagnosed. And then lack of response to specific treatments. So sometimes patients may come in with a diagnosis of CIDP and be unresponsive to IVIG. Just think about that in the back of your mind. One quick note about family history, these mutations may also arise de novo, so patients may not even have a family history at all, not even of the early cardiac death. So far and away, the most common presentation that we see with first manifestations are carpal tunnel syndrome, often that are bilateral. Other common manifestations are neuropathy, cardiac disease, and dysautonomia. Carpal tunnel syndrome, you always want to do a very thorough history about that, and often patients will tell you, oh yeah, I had carpal tunnel release many years ago, and maybe the symptoms actually came back. This was a paper that Dr. Karam did looking at a variety of patients presenting for a first manifestation of disease, and he found that the delay in diagnosis was roughly 10 years that patients had carpal tunnel syndrome before getting diagnosed with amyloid. This is also a Dr. Karam's study looking at OHSU experience, and you can see that there is often misdiagnosis with this disease. The initial diagnosis was incorrect in 68% of patients, with an average of 2 incorrect diagnoses per patient. The most common misdiagnoses were neuropathy from other forms, either diabetic or idiopathic, cardiac disease from other causes, and as you can see, CTS with associated symptoms. This is a study that we did over at BU Amyloidosis Center. Over 2 years, we looked at about 92 new onset patients, found very similar results. Many patients' first manifestation was carpal tunnel syndrome, many of which were bilateral. Our average onset of delay was about 6.7, so similar, maybe a little bit less than previously reported, and about 2.9 years for large fiber neuropathy before getting a diagnosis. Notably, I mentioned that the most common mutation, V122I, is primarily cardiac manifestation, but we found actually neuropathy in up to 50% of these patients. And many of them actually didn't report symptoms of neuropathy, but we found it clinically on exam or via EMG or skin biopsy. So what blood tests are you going to order when someone comes in with a neuropathy, working it up for the first time? I think everyone in this room would probably get your basic B12, A1C, your SPEP immunofixation serum-free light chain to look for AL amyloidosis or other monoclonal gammopathies, and your maybe a CBC and a CMP. Other things to think about, so think about cardiac manifestations with BNP and troponin. TTR, as Dr. Karam mentioned, is pre-albumin, so often this level can be a little bit lower than normal, which suggests that the amyloid is glomming onto each other and then depositing in organs, so it's going to be a little bit low in the serum. Neurofilament light chain is a marker that's been looked at very closely in amyloid with neuropathy. This was a paper looking at multiple different papers, specifically looking at neurofilament light chain with amyloid. They found that there were slightly higher levels of neurofilament light chain in patients with positive mutation but without manifestations of disease. That number also increases over time, and notably once a patient is started on a stabilizer or a silencer, that the neurofilament light chain either stabilizes or actually reduces over time. Of note, neurofilament light chain does increase by age, so you do have to sort of account for that, and it is not specific for amyloid. It's seen in any kind of neuronal damage, CNS or PNS, so it's important to interpret it in the right clinical context. This was a study also looking at patients on patisiran here over time, and you can see the neurofilament light chain level reduced over time. So this is our diagnostic flow chart. When you suspect amyloid polyneuropathy, I would argue to get the genetic test very early on, especially since nowadays it is free through sponsored testing. If you do end up having a positive mutation, then you don't want to necessarily assume it's from the neuropathy is from amyloid. You really want to try to get tissue biopsy because there can be many other causes for neuropathy. If we do get a positive Congo red sample from a variety of biopsy sites, skin biopsy, flexor retinaculum from carpal tunnel, fat pad biopsy, then often we do mass spectroscopy on this to see what type of amyloid it is. And if it's negative, this doesn't rule out the fact that it may be from amyloid, because amyloid deposits in a very patchy way. So you want to consider biopsy of another organ. I usually counsel patients, if they're going to have any kind of biopsy, whatever, a skin biopsy, an endoscopy, a polyp sampled, stain it for Congo red. PYP scan or pyrophosphate scan is a scan that looks at uptake, radionuclide uptake in the heart, and if there is a grade 2 or 3 uptake, this is also sort of counts as your tissue biopsy. So this is suggestive that there is active deposition of amyloid in the heart, and so this can also enable you to start targeted treatment. If you're suspicious of amyloid, but the genetic test is negative, then you may want to do further testing to see if this could be wild type, but it is not the hereditary form.
Let's move on to the early diagnosis and how we treat these people. We're going to show a few cases here. This is a man who's 64 years old, present with painful peripheral neuropathy. He started having numbness in his feet 3 years prior to seeing us, which slowly spread to involve the entirety of his foot. He also had significant pain at night that was keeping him up from sleeping well. And then he started having also mild numbness in his fingertips. He saw a neurologist that looked at ASPEP immune fixation, they looked at diabetes, vitamin deficiency, and they did a lot of other tests. And they ended up with idiopathic or prediabetes related neuropathy. However, when talking to the patient who reported constipation, it's not just hard stool. This is somebody who's not going to the bathroom for several days. He's also, interestingly, stopped taking his blood pressure medication because he was getting lightheaded every time he stand up, and to the point he almost passed out. He also reported several years of erectile dysfunction that was not responding to your typical medication treatment. And then when taking the family history, he did have a family history of neuropathy. That it was pretty severe in his father, led him to use the wheelchair. He also had heart issues, so kind of several red flags here. His brothers didn't have any symptoms. So on his neurological examination, he has some weakness in his toes. His gait was normal, but his reflexes were absent at the ankles. And then there was evidence of neuropathy. And then when you do the nerve conduction study, it does confirm that he has an axonal length-dependent peripheral neuropathy, as you can see on this table here. Let me maybe stop here and ask Michelle, given all these red flags, what do you think is the appropriate thing to think about here?
Yeah, that's a great question. So I think there's a couple of red flag symptoms here that should make you think about amyloid. One is new onset of neuropathy with very early dysautonomia. It's not pathognomonic for amyloid, but it's something to think about when you hear that. Also erectile dysfunction, family history of CHF. So again, this history of someone with early cardiac death in the family should raise a red flag, especially if they have CHF with preserved ejection fraction. So there's a lot of very early symptoms that should make you think, put your antenna up for amyloid.
Okay. So as you suggested before, it's good to check for TTR genetic testing. And in this patient, he did have one of the most common worldwide variant, which is the P-Val50 MET. And it does start with neuropathy. And then at this stage, as you showed us before, the question is this what's causing the neuropathy? Most likely yes, but it's always good to have a little bit of additional proof of that. And then you can go two ways. You can obviously do a biopsy at this time, like a skin, fat aspirate, or nerve, which is pretty invasive, but if needed, you can do that. But what we also use very frequently is the PYP scan, because that's an image of the heart, and if the ASPEP immune fixation is already negative, so you ruled out the monoclonal gammopathy, and if the PYP scan comes back positive, then you actually don't have to do any biopsy. So it's kind of like a shortcut, if you will. And this is what we did in this patient. Interestingly, despite the fact that they didn't have any heart symptoms, no shortness of plastic exertion, no swelling in the legs, his PYP scan came back positive, as you can see here, grade 3, and at this point we can start treatment without waiting any further. So he was started on one of the drugs. I'm going to discuss these later. And the other cool thing about these medication, you can actually track the prealbumin levels, and they dropped. And what's really good about these drugs is a lot of time they stabilize the neuropathy, sometimes they improve it a little bit as well, and they improve the quality of life.
So I think there's a few take-home messages from this case. One is to maintain a high level of suspicion. Really do a very thorough initial intake asking about autonomic symptoms with your patients with neuropathy, as well as focusing on family history. Utilize genetic testing. So now, I think in the past, genetic testing was your rate limiting step to ordering amyloid early off the bat in your initial panel. But now it is free. It's free through Prevention Genetics, through sponsored testing. So there's really no reason not to check for it if you're suspicious of it. Patients will not be charged. The cost is a non-issue. So think about this earlier on due to that. Try to diagnose your patients as early as possible because, again, this is a genetic treatable neuropathy, and earlier treatment will prevent disability and decrease mortality.
Okay, so let's talk a little bit about the clinical trial informing treatment decision in ATTR polyneuropathy. So you have diagnosed your patient with amyloid polyneuropathy. There's two things that you need to do is make sure that the disease don't progress and that the amyloid doesn't spread, but you also want to improve the quality of life by treating the symptoms. So we're going to talk about mainly the disease-directed therapy, but for the neuropathy, it's really symptomatic management with pain medication. For the autonomic dysfunction, you're going to treat the orthostatic hypotension, the GI issues, and so forth. So this is just to remind you again what happens with TTR. The liver is the main organ that makes this protein. So back in the 90s, the first treatment was actually liver transplant for these patients. And it was successful in some patients, especially if done early. The challenge is that obviously you cannot find a liver very easily. The wait time, I think there's over 3,000 people right now in the United States waiting for a liver transplant. The other issue is that there's nothing really wrong with the liver itself. Actually, when you remove the liver in these patients back then, you could give it to somebody with cirrhosis. Now, eventually, 20, 30 years later, they may develop amyloidosis, but that was something good for them anyway because it gave them 20, 30 years. So now we don't really do liver transplant. What we do is that we give people medication that target the liver and interfere with the RNA processing and the DNA translation of the DNA to the protein. And this way we drop dramatically the production of the protein. Another way to treat this disorder is to give medication that attaches to the transthyretin protein and makes it stable, so it prevents the dissociation and eventually misfolding. And there's ongoing research to look at the amyloid fibril degraders as a way to remove these once they have deposited in the body. So let's first start talking about the silencers. These are going to be either small interfering RNA protein or molecule or antisense oligonucleotide. So patisiran and vutrisiran are the siRNA and the eplontersen is the ASO. And as you can see here, they dramatically reduce the circulating TTR in the blood by about 80% on average. So anywhere between 70 to 80% with these drugs, and pretty rapidly. And the other interesting thing that we didn't show slides here, the effect is persistent. So if you follow these patients over 5 years plus, there's no change in efficacy of the drug. They continue to have strong suppression of the TTR protein. And you can check that in your patients by measuring the prealbumin. So the first trial that was done, there was Apollo, and there was another trial with inotersen. Inotersen has been removed on the market and been replaced with eplontersen, so we'll not discuss today. But the first trial with Apollo was a patisiran versus placebo, 2-to-1. And what they show is that the neuropathy progression in people who got the medication slowed down significantly. Not only that, it actually improved. Whereas the people on placebo, as you can see here, they worsened, and as Dr. Kaku told us earlier, they worsened rapidly. Same thing with the quality of life. Quality of life improved in patients who were on patisiran, whereas people who were on placebo continued to get worse. These are dramatic results, rarely seen in genetic disorder. By the way, you've been here at the meeting, so if you see something similar, let me know. You don't see something similar. This is really dramatic improvement with these patients and effect on the disease. This is a study that shows beyond the study duration. This is going up to 5 years. And I have patients who have known for over 10 years with this condition on treatment, and they're really stable. I see them every now and then, and they're doing great. So very important response in our patients. This is just segregation patients on, depending on if they're improved, they're stable, or if they worsen. A lot of time we tell people that, the goal is to stabilize the patient, and in over 50% of people you can stabilize them. Unfortunately, there's still a small proportion of patients that progress. Typically, these are people who are diagnosed earlier or with very rare variants that are pretty malignant, and a proportion of patients improve as well. So following the success of patisiran and inotersen, the companies worked on making the drug a little bit easier to administer. So patisiran was given intravenously with pre-medication every 3 weeks. So the company came with vutrisiran, which is under the skin once every 3 months, given by a healthcare provider. Now, because we cannot compare patients to placebo, because it's unethical, we have a drug that dramatically improves. The FDA allowed the companies to do trials comparing to historical placebo. So again, comparing to historical placebo with vutrisiran, you can see the stabilization of the neuropathy impairment score and the quality of life. And then eplontersen is an improvement of inotersen. It's given once a month under the skin by the patient themselves. And they also did a study comparing to historical placebo. And here also we see stabilization of the neuropathy impairment score and improvement in the quality of life of patient who got on eplontersen compared to the historical placebo. Other things also improved. The neuropathy symptom and score improved, the physical HR quality of life, nutritional status. So a lot of these patients, remember, lose weight. And in these patients who ended up on eplontersen, were in a stable. The other thing is that depending on the PND score, still people did a pretty good response. We used to think that people are pretty advanced in the PND4 or PND3 may not benefit that much, which remains true, but it's not as bad. So still I would start these people on medication even if they are diagnosed later on. Also looking at the autonomic symptoms. So autonomic symptoms are the one that really affect the quality of life the most in our patients. And you can see here that many of them improved actually, which again is unseen in this disorder that is progressed despite without treatment, regardless of what you do. GI, urinary issues, autonomic neuropathy, and on testing with the deep breathing, you see that there has been improvement in these patients. So what is the difference, and how do you decide to choose one or the other? The most convenient are going to be eplontersen and vutrisiran. Patisiran is given IV. I really rarely use it these days. I have a handful of patients who just like to go to the infusion center, and they insist to be on it. But the majority, meaning 95+, have switched to either vutrisiran or eplontersen, which is just more convenient. So eplontersen is given once a month. It's an auto-injector, pretty easy, and the patient does it themselves. Whereas vutrisiran is given once every 3 months. However, they have to be administered via a healthcare worker. The other thing about vutrisiran, it's also approved for cardiomyopathy. So the medication can help both with the heart symptoms and with the nerve symptoms. Now, obviously, all of these medications will help with both because they're doing exactly the same thing. But the trial has not been completed with eplontersen, and the trial with patisiran was not felt by the FDA to be enough to get it approved. Remember, all of these medications are interfering with the TTR production, which transport vitamin A. So the recommendation is to supplement people with vitamin A. Most of the other side effects are really minor, so we don't really see them that much in our patients. Sometimes pain, arthralgia, and so forth. Now, what about the other medications, the stabilizers that we mentioned before? So none of them are approved by the FDA for treatment of the neuropathy. However, we know that they do work for the neuropathy. So I tell my patients, if they end up on one drug or the other, that's fine. You don't have to worry too much if you're not on an FDA-approved drug. And there's several of them. There's diflunisal, which is an anti-inflammatory drug, very cheap, by the way, and you can order it from the pharmacy and the patient go pick it up. You don't need pre-approval. There's tafamidis and acoramidis that are targeted towards the heart. Interestingly, acoramidis, they're having a trial that's already started to treat pre-symptomatic patients. So if you have patients who know that they have the genetic variant and they're very worried, they can enroll in this trial. The purpose is to see if you can stop the onset of the disease. So I think this is a very important trial because eventually we may even prevent the disease from starting and not waiting until the first sign appears to start treatment. It is going to be a long trial, because you have to follow people up to 5 years plus to see if they develop the disease or not. As I mentioned, when you're targeting the TTR, although the drugs are approved for neuropathy or for cardiomyopathy, really the effect is the same. This is something not natural that we're doing, but we are reducing the TTR production, we are stabilizing the TTR, so it's going to really help with both the neuropathy and the cardiomyopathy, and this has been shown in a few trials so far. The eplontersen, there's an ongoing trial. This is the largest looking at the heart outcome, and it's estimated to be completed. At least we'll have the primary endpoint in 2026. What about the future? So believe it or not, for a rare disease, we really have a crowded space, which is good. We really like to have as many options as possible rather than no options at all, or the option of liver transplant, which is very inconvenient. So I think we're lucky in our neuromuscular world and people who take care of amyloidosis because we're seeing drugs that have been used for the first time, really first in humans. Take, for example, the nexiguran, which is a CRISPR-Cas9 therapy that has been shown to reduce safely the production permanently of TTR in humans. So there's already a paper published in the New England Journal of Medicine that shows you how this works and proves that there's a reduction up to 90% of the TTR production. And there's going to be also a follow-up on that soon, also showing that in a phase 1, so in an open label, the effect on these patients. The other thing is that there are ongoing clinical trials, both in neuropathy and in cardiomyopathy, looking at the effect of CRISPR-Cas9. Other drug, nucresiran, which is a new version of the vutrisiran, is given once every 6 months, so even more convenient than the every 3 months that is currently done. And then there's at least 3 antibodies, which are, we call depleters, that attach to the amyloid and try to stimulate the immune system to kind of remove them from the body. Okay, we're gonna move on now to Dr. Kaku again, how I think and how I treat.
Oh, I think this one's actually your case.
But this is my case.
Yeah.
It is my case. I remember. Sorry about that. But I'm going to ask you about my case. So this is a 68-year-old man. He actually came all the way from Taiwan to see us at the University of Pennsylvania, and he started having symptoms back in 2021 with numbness starting in the hands, spreading to the elbows, and then the legs became affected. He had cramps in the calves and electric shock sensation. He had difficulty gripping, buttoning, tying shoes, and he must look at things to hold them because he just cannot feel them. He also reported visual floaters that were obscuring his vision. And because of his rapid progression of neuropathy, his weakness in the arms and legs, and numbness and tingling, he was felt to have maybe chronic inflammatory demyelinating polyradiculoneuropathy and started on steroids without improvement. Then IVIG was added, but he still did not improve. He was using the walker. He wasn't able to climb stairs. He had 30 to 40 pounds weight loss unintentionally. He had decreased appetite and nausea immediately after eating. He had all of a sudden diarrheas. We just eat a bite and all of a sudden he had to go to the bathroom, nausea and early satiety, and autonomic dysfunction with urinary hesitation, postural hypotension, blood pressure systolic going as low as in the 60s, and he even passed out a few times. So what do you think, Dr. Kaku? All the red flags are here, I think. So.
Yeah, totally agree. So just to hit the hammer home, rapidly progressive neuropathy, early motor involvement, early dysautonomia, unexplained weight loss over time, and we talked about misdiagnoses. So CIDP, definitely a common misdiagnosis because it can be a rapid motor progression of neuropathy, especially if it's not responsive to IVIG.
So this is his exam. It confirms that he does have neuropathy, the reflexes are absent, the sensation is impaired. And what's interesting is he had both proximal and distal weakness, which would make you say, yes, not a lot of things can cause that, so let's think about CIDP. So not a wrong thought, in my opinion, but obviously he did not respond to treatment. Also, CIDP never gives you dysautonomia or weight loss or all of the other visual floaters and so forth. It's really pure neuropathy. So anything that is outside of the nerve system, you have to think twice. And obviously the nerve conduction study are key in the diagnosis. CIDP is a demyelinating polyneuropathy, whereas amyloid is an axonal polyneuropathy, in which is demonstrated here. Severely reduced CMAP amplitude, absent sensory all throughout, and a normal conduction velocity apart from the presence of bilateral carpal tunnel syndrome. So in this patient, because of the aggressiveness of the disease, we did kind of everything. We did genetic testing. We also did the nerve and the muscle biopsy, which if you look here, the muscles show that he has a Congo red, the position, the nerve. This is the fat around the nerve also had, as you see, the green birefringence on the polarized lens. And then when you look at the semi-thin, you see reduction mainly of the small myelinated nerve fiber, typically what you see in amyloidosis. His heart wasn't really involved that much, slightly impaired BNP, and when the PYP scan was negative, so again, why the nerve biopsy is important here, because you have to prove that this is what's going on, and not a lot of cardiac involvement. Okay, so this is a study we did a while ago, looking at how neuropathy progress in different disorder, and Dr. Kaku mentioned this earlier, but if you look at CMT and diabetic polyneuropathy and follow them over a year and examine them, you don't really see a lot of changes on their neurological examination. They look about the same, even though, but perhaps the patient may complain of more of pain, etc. But on your exam, the strength is not changed that much, the reflexes are not changed that much, the sensation is not changed. However, if you have a patient with amyloid polyneuropathy, especially the non-V122I, and you do see them a year later, you will see much rapid progression with weakness, more loss of reflexes, and spread of the sensory loss. So in this case, we're going to target again the disease itself by using the 3 medications that we mentioned before, patisiran, vutrisiran, or eplontersen, depending on what the patient chooses, and then managing the symptoms, which are really annoying for the patient. So loperamide for his diarrhea, midodrine for his orthostatic hypotension, and pregabalin for his pain. Okay, now it's your turn.
Thanks. So I'll be talking a little bit about developing a multidisciplinary amyloid clinic and what that might look like at your institution. So why do that? As we talked about, neuropathy from amyloidosis is really a multisystemic progressive disease and really affects multiple organs. So really we can't do it alone. We really need the help of our colleagues in other subspecialties to help us with early diagnosis, and initiation of treatment to make sure we're really addressing all of their organs. As of August 2025, there's only 56 amyloid clinics in the US, and of these, 52 have a neurologist on staff. So what might the infrastructure of an amyloid center look like? I would say at its core, you probably need a neurologist, and a cardiologist, because those are the 2 main people that are taking care of the organs that are affected the most. It would be helpful, although not 100% necessary, to have many other subspecialties of which we know amyloid affects those organs. So hem-onc, nephrology, gastroenterology, ophthalmology, and a pain specialist. Great if you have an infusion center in your hospital, in and around it, that can help facilitate getting some of these injections. And then the surrounding core team, genetic counselor, clinic manager, pharmacist, MA, are all very helpful in order to make the clinic run smoothly. At Mount Sinai, we have a multidisciplinary meeting where we meet every 2 weeks to discuss patient cases that we've seen in the recent past, so we can talk about really holistic care for the patients. You can also do things like include EMR order sets. So there's a pretty large battery of tests that we initially order up front. So helpful to have like either a dot phrase or an order set that you can use easily. And you can also use disease-specific screening tools and standardized care protocols. In your workflow, you want to identify patients with red flag symptoms, as we had talked about, evaluate them clinically, rule out AL amyloidosis with our SPEP immunofixation serum-free light chain, and potentially, if needed, further workup with a hematologist. Get either a PYP scan of the heart or tissue biopsy with genetic testing. Again, you don't necessarily need tissue if your PYP scan is already positive. And then once you identify your patients, serial monitoring over time with these specialists are important. So I don't do all of these things in my clinic. I do a neuropathy impairment score every time I see a patient, which is typically roughly 6 months. It's basically a regular neurological exam with a few additions. Grading their PND score over time. So often insurance companies want this just to know if there's actual true disability that the patient has. Rausch disability score. This is a series of questions that ask if you have mild, moderate, or severe impairment in various things like writing, eating. Compass 31, is a questionnaire looking at autonomic symptoms. And autonomic screen, I usually will do a brief questionnaire and then also have orthostatics done on each patient every 6 months. Cardiac monitoring, you can get a NT-proBNP and troponin as a baseline. Often these patients will come with an echo, scintigraphy like PYP, or cardiac MRI, as well as renal labs. You want to keep track if they're starting to develop proteinuria, for example. And then treatment, you want to initiate your gene silencing therapy as first line. Often patients, if they have only cardiac involvement, may come on only a stabilizer, so it's helpful for you to assess them if they need a silencer. And then, as Dr. Karam said, symptom management. Estimated expenses, so this is quite interesting. This is a ChatGPT-5 assessment looking at all of the various journals on the bottom to tell us about the expected expenses and revenue of an amyloid clinic in the first 5 years. So the estimation is an initial investment of 1.5 million to 5 million in the first year, staffing of about 5 to 7 FTE staff for a small clinic, managing about 100 to 200 patients annually. As I said, the staple is going to be your neurologist and your cardiologist, as well as additional helpful support staff. And then potential revenue could be anywhere from 500,000 to 50 million per year, depending on the size of the clinic. And you can see that over time, the revenue will far exceed the total cost of the clinic. Amyloid clinics also provide a lot of education for residents as well as fellows. It helps to support education development of future amyloid specialists. These trainees will go out into the world and be able to recognize amyloid themselves earlier. We'll also help trainees with patient evaluations using various assessment tools, history taking, supervised procedures like EMG, skin biopsies, etc., what to look for on follow-up visits, and great to include them in multidisciplinary care discussions with other providers. There's many ways in which you can involve trainees into an amyloid clinic, as you can see here. Notably, the International Society of Amyloidosis provides funding for a fellowship for amyloidosis if you're interested. So if you have a structure set up, they will actually help to fund you via a grant for 1 year salary for a fellow. Great. And this is my case. So the last case of the day, I'll be talking about a 37-year-old with a known family history of amyloidosis. So this person had ASP18-GLY TTR genopositivity that was found in 2011 due to his family history. He was pretty asymptomatic up until 2016 when he started to develop a little unsteadiness on his feet, several episodes of vertigo, some cognitive difficulties and word-finding difficulties, an episode of dysarthria, and he also developed some intermittent unilateral tinnitus. We knew that he had a significant family history in his mother, who had developed hydrocephalus at the age of 43. She had had a VP shunt placed with repeated blockage requiring 3 replacements, and eventually analysis of the CSF fluid came back positive for Congo red. She had an orthotopic liver transplant at age 55. Again, this is when there was really no other option. She unfortunately progressed to develop cardiomyopathy and CHF and died 4 years after liver transplant. In our 37-year-old gentleman, this was his workup. Notably, his prealbumin was 10. Again, prealbumin is transthyretin, was a little bit low. His CSF protein on spinal tap was 89, so a bit elevated. He had a negative fat pad, negative EMG, negative EEG, a retinal ophthalmology exam that was negative, EKG and TTE, which were normal, and ultimately brain MRI with and without contrast that demonstrated hydrocephalus, leptomeningeal enhancement around the brainstem, extending into the cervical spine. His MRI orbits were normal, and his OCTs demonstrated normal macular volume and fovea thickness. Very importantly, his neurologic exam otherwise and his neuropathy impairment score were 0, so he did not have evidence of neuropathy on exam. Initially, he was started on diflunisal and EGCG. He had a third ventriculoscopy, and surgical pathology demonstrated some minimal reactive gliosis of a right frontal biopsy. He had a VP shunt placed in 2018, and in 2019 he was started on tolcapone. So why tolcapone? I mentioned this here. This is not an FDA-approved treatment, but notably, the TTR silencers do not cross the blood-brain barrier. Tolcapone is a TTR stabilizer and has been demonstrated to cross the blood-brain barrier. These are in studies looking at CSF studies measuring transthyretin after giving tolcapone to patients. Of note, tolcapone does have a black box warning for liver toxicity, so very important to be monitoring these patients over time. And also notably, no large randomized study has been done to look at this, nor will it likely ever be, because tolcapone, as you all know, is a medication that's currently out and used for Parkinson's disease. But again, this is really one of the only medications that we have that crosses the blood-brain barrier. There are, of the 150 TTR mutations, about 14 that have eye and CNS involvement. We call them the oculoleptomeningeal variants. And these patients can present with headache, transient focal neurologic episodes like this episode of dysarthria, an episode of confusion, oftentimes with normal EEG, cognitive difficulties, ataxia, and also hearing loss and tinnitus. Some notable features in these variants include elevated CSF protein. The brain MRI can demonstrate leptomeningeal enhancement diffusely, hydrocephalus often needing shunts, and unfortunately multiple shunt revisions, and superficial siderosis, and head CTs may demonstrate hyperdensities along the sylvian fissure. This was not this patient, but this was a case report of 2 patients with leptomeningeal disease with calcifications in the cortex along the sylvian fissure.
The key takeaways from today's symposium, and I hope you all agree with us, is that this is an important disorder. It's genetic, it's rapidly progressive, and there's some specific signs that can suggest that the patient may have the disorder, even though they varies from members even within the same family, and depending also on the variant of the gene testing. The current treatment have really revolutionized the way we approach our patient and have dramatically changed the outcome. But the earlier you start them, the better. So keep an eye on. That's why we're doing this program anyway, to kind of raise awareness. And although it was felt to be rare, I think more and more we're seeing large number of patients, large families that have it, and then the collaboration between cardiologists and neurologists is also increasing the chance of finding these patients. So you can ask, I think we can just take maybe 2 questions because we're up on time. I have a few listed here, but I would, if you have any questions, you can also type them on your phone. So the first question is, how sensitive are nerve conduction studies in detecting early amyloid polyneuropathy? That's a great question that we struggle with a lot. Remember that neuropathy can start with small fiber being affected, and the nerve conduction study only study the large fiber, so you will not pick it up. The other thing is that there's a range of normal in patients, and if you have a Searle of 8, it may be abnormal in a 40-year-old person. And some older people may have completely absent Searle, and that could be a normal finding. So the next question.
I will also just add, we're actually writing up a paper now looking at sensitive measures of nerve conduction with in amyloid specifically, and we actually use the SR-AR ratio, the Searle to radial ratio, which is a little bit more sensitive than just looking at the absolute value of your Searle nerve. It's comparing it to the radial, so it's using the person as to see if it's a length-dependent process. So that might be something to think about employing in very early neuropathy, but as Dr. Karam said, your nerve conduction study could be completely normal, and you might need to go to a skin biopsy to diagnose it if it's small fiber.
I'll do the second question.
Sure. Let's see. Along with supplementing vitamin A with gene silencer treatment, do you check their vitamin A level? If it's low, do you increase the supplement? That's a great question. So as we discussed, all the silencers are going to lower your vitamin A. I don't actually check the vitamin A after initiating treatment because you would expect it to be extremely low. Usually it's going to be like less than 3, which is basically 0. And often the patients, if you do check it, start to get worried and are wondering if they're not on enough supplementation. As long as you're giving them regular supplementation, which is not any more than what's recommended daily, you don't need to serially check it. You don't need to increase it if you accidentally check it and see that it's very low. The way that you monitor it is really just asking the patient, are you taking your vitamin A? Are you having blurry vision or darkening of vision at night? Can you have difficulty seeing at night? Because lack of vitamin A can cause night blindness. But I don't check. Do you check your vitamin A's?
Okay, so we're gonna probably stop here. Thank you again for joining us.
Thank you so much for joining us.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent educational grant from AstraZeneca and Ionis Pharmaceuticals. To access all materials for this activity, visit peerview.com/AJT860.